one of the things that today we are going to learn is about patient-centeredness and patient experience, which we all mentioned yesterday. And from the comment that I heard that we need to call our patients guests is actually a plus, meaning that we are moving away from seeing our patients as patients, but actually seeing them as variable people who we need to involve as they receive care. And not just because we are calling them guests, because they are bringing the dollar and paying for services, but because we value the addition that they are going to bring in the healthcare system. So this morning we have 2 sessions. We'll kickstart with the first session, which is engaging the patient and families and creating patient-centered engagement at the facility level, and also measuring the impact and driving the change. Our first presenter will be Benta Omonge. She's a certified patient experience professional from the Beryl Institute in the US. She's also a council member of the Beryl Institute and a member of the Global Experience Measurement Committee, an international panel engagement in the development of experience measurement tools. Her background training is in nursing and public health and health profession education. She has a wealth of experience in nursing practice, nursing administration, and health profession education. Currently, a PhD, a scholar in leadership and organizational development and patient experience. Her previous portfolio include research in mentorship, nursing nutrition, and reproductive health in young adults. She has contributed to numerous protocols and guidelines in nursing practice, including chapters on medical nursing, critical care in the nursing practice manual. So let's give a round of applause as we welcome Benta Omonge.
Good morning, everyone. Can you hear me at the back there? Yes, I think so. Okay, that's a lot of, it's a long list right there, but today we will just look at what patient experience is all about. It has become my pet subject lately, and when I find an opportunity, I talk about patient experience and hope that eventually we will all get to understand and practice patient experience. I hope you have my slides. We can start actually. As that goes up, it's important to share the beginning of patient experience, the journey, the model that was mooted about 2010 is not a very long journey that has been. A group of persons passionate about patient experience thought a good idea it was to start what we call patient experience journey. So the intention was to elevate the experience of the patient from what we have known them to be historically to make them what some of us are calling guests, so that we give them care that we ourselves would like to consume. And so based on yesterday's question, how many of us would go to the facilities they work for? I certainly would go to the facility I work for, because I do know that we have over time tried very hard to address the patient experience issues and tried to get staff to perform in that direction. So we can move on to slide 1. Okay, I wanted us to make this clear, some clarity here, patient-centeredness and patient experience defined, because there is some subtle differences that I'd like us to share. So patient-centered care is what we have talked about all of yesterday. And we were very concerned about making sure that quality is right and that patient's care is safe. And everything we do is centered on the patient. So the definition up there is what patient-centered care is. But look at the definition for patient experience. And this was a definition that was put together by the initial community of patient experience practitioners. And we said that patient experience is a sum of all interactions shaped by an organization's culture. We talked about culture yesterday, and this is where it sits, that influence the patient's perception across the continuum of care. Perception across the continuum of care, meaning from the time the patient decides to come to your institution for care, how they contact you, who they meet on the phone, when they get to your hospital, who they find at the entrance, the persons they meet along the corridor, the cashier, the records person, the doctor, the nurse, the clinician, and everybody up to the discharge counter, and at least 2 to 4 weeks post-discharge, what sort of experience they go through, that is what we considered the continuum of care. So, next slide, please. Why was this important? This we considered was important because at the center of all we do sits the community, sits the workforce, and the patient sits right in the middle of that circle. And all of this we put together as a human experience. These three are completely intertwined. You cannot do one without the other. And so we decided to elevate the human experience exclusively so that we could get patient experience really a lived experience. So patient experience and workforce are inseparable, as I have said. So elevating the experience of the patient is what we hope organizations or hospitals would strive to achieve, because that is what makes the differentiator between hospitals, and that is what makes hospitals leaders in the industry. Why focus on the experience? Next slide, please. We also noted that about 80% of health outcomes are determined by factors that occur outside of the medical treatment. So all of the treatment we give, the quality patient safety, all of those aspects we looked at account for 20%. The 80% that is left looks at other areas. So the more reason why focusing on physical, mental well-being of the patients becomes important, and that of the care provider. Provide social activities and well-being programs that address those issues, the need to train staff on how to interact with patients and family, and be alert to biases that may affect the welfare of the patient. So all of these make up the remaining 80%, and so the position of patient experience becomes very important. However, to get this right, there's some foundational aspects of experience strategy that one must have in place, and some of these we did try to do in our institution. It's important, first of all, that the experience becomes a strategy of the hospital. It must be aligned to the hospital's overall strategic plan so that it's given the attention it deserves. So there are about 8 principles. If you go to the next slide, please. It's important to identify and support accountable leaders. For it to be able to work, you must have designated persons who will run the strategy of patient experience. Otherwise, it is very difficult to get it off the ground and to get it running. You have to develop a formal definition of experience. Although at the beginning we did have a definition, it was agreed that organizations were free to adopt it or to modify it to suit their cultures, so that you have a defined definition of what experience is in your organization. We needed to, I'm on the next slide, please, to establish and reinforce a strong, vibrant position about the organizational culture, because without a proper culture, you cannot run a successful experience. And then we needed to implement a defined process for continuous patient and family engagement and community partnerships. So those three, engage the family, engage the workforce, engage the community, so that you have a comprehensive patient experience process journey. Next slide, please. The other foundational experience need is to engage the voice of the staff, the voice of the clinician, the voice of healthcare professionals, to be able to drive a comprehensive and lasting solution to whatever problems that you discover in your institution, or ensure an active commitment to both health equity and access to care. And the last two would be expand focus on health outcomes beyond just the illness to promoting health, wellness, and well-being, and acknowledge the healthcare experience that reaches beyond clinical interactions to all touch points across the continuum of care. So we did address completely, comprehensively the quality items, the safety issues, but we just mentioned, there were 2 questions, I think, 2 participants yesterday asked, what about the person who is receiving that care? And so I hope that we'll be able to address that area going forward. Ordinarily, on the next slide, please. Ordinarily, our leadership in hospitals measure 4 aspects of care. Here, our everyday today activities focus on clinical outcomes, and this we addressed again. Clinical outcomes are measured on a daily basis. But leadership also looks at the financial outcomes. We look at revenue, we look at cost, surplus, we look at funders, we look for funding. Customer satisfaction is measured across many institutions, and we've had this battle about trying, not a battle really, but trying to persuade us that we move away from customer satisfaction to what we now call patient experience. And currently in use, people use things like the Net Promoter Score. They look at promoters and detractors so that they get a customer satisfaction, which doesn't quite describe the patient experience. And then lastly, the community reputation. This is measured across many organizations, and people look to see what the patients and the family experiences would be. It's important to note that for the community reputation, one is to take special care here, because the community reputation also speaks to the brand of your organization. Healthcare facilities are a fundamental part of the communities that we serve, because whether we like it or not, we have a regular interaction with the community we serve. So they will tell stories about your hospital. They will tell stories, whether they're oral or written, like the one we had from Bagathi yesterday, or through social media. They will complain and compliment with equal measure their experiences at the hospital. You do not have to participate in this, but they will tell your stories. So those interactions, which are available and available information about institution, plus the accessibility to your hospitals, and the presence of the staff when the patients visit our hospitals, and as well as commitment to the well-being of the community, are very important, because these items will define the reputation of the hospital. And we all know that reputation drives choices, and patients today have a wide array to choose from. Choices are driven by experience. So if my experience is bad, for sure, I will not choose to come back to the facility that has given me a poor experience, but where I have been treated as a guest, as a very valuable member of the facility, I will certainly be able to encourage other people to come to the same facility. So those 4 items are important. But having said so, what then are important matrices in patient-centered care? And I've gone back to patient-centered care. Now, quality and patient safety matrices are driven by the quality management standards. Most of the time, this is how it is practiced locally, that depending on what quality standards each hospital is affiliated to, is ascribing to, whatever quality standard defines is what we will try to measure. And we saw that in a number of cases yesterday presented here. We also were told about risks, and these are also measured, risk identification and management. Then we look at non-specific indicators. These include falls. We saw them from the Ministry of Health. Falls, pressure ulcer formation, hospital, and we're told is healthcare acquired infections. These are regular measures. And then there are clinical outcomes, like mortality rates, readmission rates, the return to theaters for surgeons, and the complication rate. Those are ordinary, regular, patient-centered care measures. And also the need to accreditation. For example, those that are seeking accreditation, and most of the hospitals in Nairobi today, or around today, private hospitals specifically, are looking to get a Joint Commission accreditation. So whatever is assigned, listed in the accreditation process, they will strive to do it. And the current edition of the Joint Commission Accreditation Standard, which is the 8th edition, 7th edition, has included an entire chapter on patient-centered care. And so if you want to be accredited, the list is long. Actually, there are about 63 items that you must subscribe to. So it is indeed a global concern, really, what should get measured. If I move to the next slide, please. And a lot of studies have gone into what is important to measure if you're looking to implement a successful patient experience activity in your hospital. I looked up some. I found at least 10 of those measures that are already in literature. However, I picked 2 that appear to be commonly used, even though they are not named as such. Yeah? Could we please move on to the next 2 slides? I think we're behind there. So I picked 2 that I think are used commonly. And if we get to the correct slide, we'll be looking at a slide that talks about what the Institute of Medicine has endorsed as areas that are important in measuring the patient experience. The aim of the Institute was to improve quality, safety, and overall experience of the patient. The areas they looked at would be respect to patient values, preferences and expressed needs, would be coordinated and integrated care, would be to provide information, communication, and education, and those are loaded topics in themselves. It was seeking to ensure that patients have physical comfort, that we provide emotional support, and that we involve family and friends in the patient's care. Next slide, please. Okay, the next one. I need you to catch up with me, thank you. So looking at the endorsed, the 6 endorsed patient-centered care items that were being measured, it was also interesting to note that of all these that were listed, none of the standards were able to measure what was required unless the patient was able to give feedback about the tools that were identified. So I was able to locate at least two separate tools for every item, every dimension of the IOM endorsed patient experience measures. But that was one I looked at because I think that we commonly address the dimensions mentioned there, even if we are not calling them IOM dimensions. And we also, in many of our hospitals locally, are looking at what is called the PICA Patient Experience Questionnaire, if you move to the next one. However, this questionnaire is fairly close to the IOM questionnaire, but it has additional items to make a total of 8 areas that need to be addressed. And some institutions use it, but they have not labeled it as such. And so I thought these are the closest to what experience has been measured at in our local setting. Next slide, please. And so about the PICA's questionnaire, the good thing about it, and this is available if anybody wants to have a look, it has a 15-item questionnaire. The good thing about it is that it allows for customization of some of the aspects it seeks to measure so that it is able to fit into your organization's culture, so to speak. And one is then able to discuss the scores quite easily and be able to implement whatever changes you wish to. And so that would be another tool. But there are, as I mentioned, quite a number of tools, and I was able to locate about 10 of those. However, those that are commonly used outside of our region include the Customer Assessment of Health Provider System, but this is linked to reimbursement of those institutions. So depending on the outcomes and the patient's feedback, then the organization is reimbursed in terms of funding. And I think this is what SHIF is going to address. And as I spoke to Dr. Harry at the back there, I wondered about the allocation of patients to institutions so that one is able to attract a reimbursement from SHIF or NHIF for that matter that was there before. The Net Promoter Score, we've used the Net Promoter Score before, but it doesn't quite express the patient's experience. It tells you about what the public thinks about your institution, again, addresses your detractors and promoters, and gives you a score. But not many hospitals look at it, so you're not able to compare between hospitals what care is like. But then there is one new tool that looks at the experience of the patient. I'd like to put a little more input into this one because it is a tool that is currently being developed. That would be the 11th tool that measures experience of our patients in our facilities. As I said, the Joint Commission is quite long. It has 5 patient-centered care standards and 63 items. You really would need a lot of time to be able to do this on a day-to-day basis, but they look at the very regular, common practices that we have in our hospitals daily. So if I move on, it now has become apparent that quality, safety are 2 aspects of patient care, but unless you add the experience as a third leg to this three-legged stool, it really doesn't sit proper. So patient experience is positively associated in a research done with clinical effectiveness and patient safety, so those two. There is support to include patient experience as one of the central pillars of quality in healthcare. And so there are three dimensions to this, which would be clinical effectiveness, patient safety, and patient experience. I know that our clinicians locally here do not quite appreciate it. It's actually quite usually dismissed as being too subjective or mood-oriented, but it's about time. And so for me, it's important that we all are able to measure the experience that we give to our patients. So really what matters is that we are able to measure what matters to the patient. Having said all that, what we are looking to measure is what matters to the patient. So special attention to the changing criteria of what matters to the patient becomes very central to what we do on a day-to-day basis. We have to understand and reinforce what the patient considers important. If you do this, you will be able to directly impact the other three measures that the leaders look at: the clinical, the financial, the customer service, reputation, because ultimately, this is the customer, this is your client, and they have spoken. And these are the things that we want to look at in the remaining few slides. So the patient-reported approach to measuring experience is what we have adopted today. It provides the patient's perspective, that's what's important, to all of their encounters as they go about their activities within our hospitals, assesses the effectiveness and efficiency of the care we have given, evaluates all the tools that we use in our diverse measures, and therefore is considered the best way to measure patient-centeredness in our care today. To be able to determine what these items were, again, 2 questions were sent out to patients, which were: when you think about having a good experience, this is to the family and to the patient, how important do you find the following? And this is what then was able to guide us towards what the patient's experience tool should look like. And you can see right there on the next slide, please. I need you to move quicker. Next. That one. Okay. So put to families and patients to tell us what is important so that we're able to measure their experience. You see the first, having appropriateness, the appropriate level of care was considered very important. These were quantified from what the patient's feedback was. So appropriate level of care was rated high at 95%. Clear communication, listening to the patient, achieving positive outcomes, those scored high, 94, 95. That my health ultimately improves was important to the patient, that my care is delivered safely, again, safety is here, and quality followed, and a clear plan of care that the patient understands followed. And then we had that the clinicians and the nurses and all the healthcare workers ask questions to understand my needs and preferences, and that they are courteous and they respect me when they address me. So these top 10 became what we put into the questionnaire that is currently in circulation, actually is on a number of test sites abroad and locally. In Kenya, we have about 4 hospitals that are trying this out. But what comes out of this questionnaire is that there are 4 specific areas that we look at. Could you go to the next slide, please? It looks at relational aspects. Relational aspects means that my care team is anybody with whom they made contact with, addressed what was important to me, number 1. Then the effort from the working team was that my care team, they made my experience as easy as possible for me. They listened to me. They communicated in a way I could understand, treated me with respect and courtesy, treated me with compassion. They treated me as a partner to my care, engaged my family, my care partners, in a manner that is appropriate to me, and I had trust in them. The outcomes that also fit into this questionnaire looked at: I received a high quality of care, and I achieved outcomes I expected And where the expectation was not met, I was told why that was not possible. And then a narrative at the bottom, which has become very useful. On a scale of 1 to 10, please rate your overall experience with our organization, or please tell us more about your response above so that we are able to understand that aspect that has not been captured in here. Now, this is a proposed tool, as I said, is circulated about 185 countries, mostly in the West. And in Kenya, we have just about 4 hospitals that have opted to try it. And we hope that when we get this done, that we'll certainly be able to see whether we are now able to measure patients' experience better. So, how do we create a patient-centered engagement at the facility level? This is really practically what is done, what we did in our facility. Management responsibility included support from top management, very important. Please go to the next slide. I'm trying to make sure we fit within the timelines. There must be lobbying for budgetary allocation because implementing the experience movement is costly. Organization and enculturation is important across all the disciplines in the hospital. Of course, there's the usual monitoring and evaluation. Employee empowerment sits squarely right there. And especially your frontline employees, you want to be able to skill them appropriately so that they are able to do service recovery at the point of incident occurring by teaching them several communication styles. And these are acronyms that we use in communicating with patients. If it is handover, you're looking at ISPA. If it is a complaint or a grievance, you're looking at HEART, etc. If it is a patient who is upset, you're looking at head approach to communication, and so on and so forth. But besides this, there must be internal audits that help you develop action plans that you look at quarterly or biannually, and then that helps you to ensure you have continual improvement. At the facility level, again, employee engagement is important. As I said, we've seen in that initial circle that the staff, the workforce, sit right next to the central part of the experience journey. And so regularly look at your staff, and you want to ask, the staff would want to give you feedback in terms of whether or not they feel valued, whether or not you're interested in how they come through, whether you listen to them, when they give you their challenges, or if you treat them with courtesy and respect, because behavior begets behavior, or if the organization effectively communicates in a way that staff can understand, so that if there is a project to be delivered, they are able to follow through. Next slide, please. Again, the importance at the beginning of every change, specifically the experience journey, that we must create awareness through procedures like town halls, symposia, training sessions, employee engagement so that there is public participation, identifying champions at the departmental level so that they run with whatever agenda you have in the patient experience journey, and accessing resources that helps them, even at their stations, to be able to regularly engage and to address what is being implemented. And finally, at the patient and family community engagement level, we now are advocating for patient and family advocacy committees. In the committee, there needs to be a mix of people. The frontline officers are very important. Your past patients who have had experiences in your hospitals when they are not patients would make the committee. Family members who are current patients would be in that committee. A patient experience representative, one that you have specifically hired for that purpose, would be in the committee, and current employees who regularly give services, a doctor or a clinician, and of course management. There must be a leader, because when you have made a decision, you want somebody who can, when you have had a conversation, you want somebody who can give a decision immediately so that changes are effected promptly. And then at the departmental levels, like in the wards, in the units, there must be regular family conferences. These are called, depending on the patient's acuity and the critical care, you need a daily engagement. In the rest of the wards, you can determine, depending on the patient's level of care. So for me, a call to action, and I'm finishing, this is my last slide. Having sat in the conversation, the global conversation around doing an experience measurement, we want to be able to measure my experience here in another hospital, so that the patient is not torn between hospitals. Because if I get the experience right here, and I go to the next hospital, I should be able to get it. But we must come to a place where we have defined patient experience in our different facilities in a specific way so we all understand what we're doing. So do we need to have a definition for our region, or can we adopt the global definition as has been given? It is imperative to devise a comprehensive framework to be able to implement. If you want to implement the journey, how do you go about it? So where is the model that we want to use? We can adopt or customize the patient experience management tool as addressed when it is finally released to the public, to the world to use. Or we can also establish individual institutional baseline evaluations of our patient experience journeys. I can tell you that when I first took the experience tool that was being used in the Western area, and I tried to score an institution that is supposed to be the best in the country, I ended up at a score of about 20%, and I could not understand why this was so. And so there may be need to customize that to fit our local situation, and then compare practices. We should be able to compare practices so that we're able to improve the experience journey. Comparing practices meaning that if the patients score us, I must not hide what I have done better, and you must be willing to share what you have done better than the other organization, so that we sort of standardize the care that we're giving to our patients. I will stop there and allow my colleague to come on. We indeed are the ones who contribute to the patient experience, so each member of the organization must see themselves as the experience advocate. Thank you.
Another round of applause for Benta Omonge. And I think something that has come out is that for this data that we measure, we must not hide. And the majority of our facilities have websites, we have social media pages, and therefore we need to bring this data out so that even patients can actually choose where they want to be treated. Thank you so much for that presentation. I want to invite our second presenter to take us through the patient experience measurement. That is Dr. Jacqueline Adidi. Welcome. Dr. Jacqueline Adidi, I want to read her bio. She has done a lot of impressive work here in Kenya and globally. She is a health system researcher with 20 years of experience. She currently serves as the director for the University of Notre Dame, Global Presence in Africa. She is also academic faculty at Strathmore University Business School and Institute for Healthcare Management. Dr. Adidi holds a PhD in Health System Management from Strathmore University, a master's in Public Health Administration with a specialization in International Health Policy and Management from New York University. And most recently completed a postdoctoral research fellowship funded by National Institute of Health at Strathmore University. She is currently a Women's Global Health Fellow with the Women Lift Global Health for 2023-2024. Dr. Adidi is an academic scholar who has widely published in subject areas of health system, health economic, specifically in maternal health, quality of care, in globally recognized peer-reviewed journals like PROS 1, BMJ. She has also served as a principal investigator and co-investigator on several grants focused on health system, human resource for health, quality of care, and maternal health. She is currently the principal investigator on a sub-grant on global health workforce program in partnership with Intra International, focused on training healthcare workers in 10 counties here in Kenya on operationalization on primary healthcare management unit. Dr. Adidi previously served as the Fold Family Program Regional Research Program Manager in charge of research focused on East Africa, spanning 3 countries. Here she was the principal investigator in 6 studies on maternal health. She previously worked at the Earth Institute at Columbia University in New York, managing and the implementation and evaluation of research projects related to Millennium Development Goals across 8 sites in 6 countries in Eastern and Southern Africa. She has also served previously and consulted for Global Alliance on Improved Nutrition, the Global Health Workforce Alliance, the World Health Organization in Switzerland, and the Guttmacher Institute and the Helen Keller Institute on projects related to health system strengthening. Her work in this institution has exposed her to working with policymakers at both government and other agencies in strengthening health system. So welcome so much, Dr. Jacqueline Aridi, a researcher. We hear what you have.